Tomorrow. All right, let's begin. Welcome, everybody. My name is Grant Wells. I'm Director of Innovation and Development for the Maternal and Child Health Research Institute here at Stanford. We are so glad you can join us here today for this really wonderful seminar that we have. I'm going to take the opportunity to share just a few quick promos and new events that are happening uh, here at MCHRI. Um, So today's seminar will be on neonatal multimorbidity and the phenotype of premature aging in preterm infants, presented by Dr. Litt, who's an associate professor here in neonatology. And just want to focus um, on our education committee who really helps put these events on. Um, a whole host of people from across um, our department as well as other departments are able to kind of help us present these important topics. If you would like to join, we'd welcome it. We have one monthly meeting each month, and it really adds a lot when we have different perspectives. So if that's something you're considering, please follow up with us. Um, One aspect is we're really excited by our Drive-In Research Pathway program. We just finished our mentor application cycle and we've opened our student application cycle. If you know students that would be applicable for this summer research opportunity, please have them attend either um, our info session or consider submitting an application. Really a great opportunity for those that are interested in pursuing maternal and child health research here on campus. We have a really wonderful array of mentors who open their labs as well as kind of dedicate time. And then we also provide them some summer programming so they can learn more about different resources and different areas of research so they can think about how to pursue a career in maternal and child health research. So those two QR codes will take you kind of to the relevant information. So please be on the lookout. Next is our upcoming topic featuring Sergio Scadis on December 8th, really around AI in pediatric imaging. It'll be a great opportunity. Can't think of a more compelling topic just in this day and age. All these things that are happening here on campus in AI, and I think he's a wonderful speaker who's newer to Stanford, so we can kind of learn about this important topic and kind of where it's headed. So sign up for that using that QR code. There, you can also go on our website, and we also post this information in our newsletter. We want to specifically call out the David Cook Jr. Foundation for Kidney Health Innovation Awards. This is a new philanthropic opportunity that's been raised. There's seed grants for up to $300,000 over 2 years, and postdoc support for up to 100K per year for 2 years. The submission deadline is February 2nd in the new year. We have the notification of the grant recipients in April, and then the award start dates in May. So if you're interested in an area focused on kidney health, um, please take this to heart. We're really looking to make transformative discoveries with these awards and maybe potentially bring others who are, have areas of research that might be applicable and really apply it to kidney health. So, um, if this is an area of interest, please consider applying. But want to turn our attention back to today's topic, and really delighted to have Dr. Litt with us today, presenting on this really important topic, really one that I think is worthy of our consideration as we think about the life course, areas of opportunity and collaboration that exist, as well as kind of a newer topic based on some of the data that's been generated. So, Jonathan, I will let you share your screen and stop sharing mine and let you take it away.
Great. Thank you so much, Grant, for that introduction. Let me just get my slides up. It's such a pleasure to be here today speaking with you and this group about some of my work on neonatal multimorbidity, as you see here, and sort of some new thinking about how we perceive the developmental trajectories and the health trajectories of infants who are born early. Um, I think this is really great timing. I didn't actually select this, but the nice coincidence that yesterday actually happened to be World Prematurity Day, so I think this is an apt topic for this week for sure. So in this next 50 minutes or so, I hope to cover a bit of ground. So if you'll bear with me, so we walk through this together, thinking about what is multimorbidity and how does it differ from comorbidity and special healthcare needs. What are the links between physical health and development in children who are born early? There's been some interest in using multimorbidity in the neonatal period for risk prediction for later developmental outcomes, and I'll spend some time thinking about that. And then really thinking about, is it time for a new paradigm of risk and bringing in this concept of accelerator or premature physiologic or cellular aging. So first, just to go over some definitions and clarify these distinctions, and I call them distinctions with a difference. So I think we're all, probably aware of either in our clinical lives or just our personal lives, the idea of what a comorbidity might be. Defined as a disease or medical condition that is simultaneously present with another or others in a single individual. Um, which condition should be designated kind of the index, and which the comorbid condition is actually not self-evident and may vary in relation to the research question at hand, the disease that prompted a particular episode of care, or the specialty of the attending physician. And here in this diagram, you see you might have a gastrointestinal problem and comorbidities in any other sort of domain, but it really is in the eye of the beholder how one defines that index problem and the comorbidity. This is in distinction and sharp contrast, I think, to the idea of multimorbidity. And it really shifts the focus in an important way to the individual. And it's defined as co-occurring conditions affecting multiple organ systems in an individual. In the adult world, it's associated with dysregulated bodily functioning, risk of rehospitalization and other healthcare utilization and costs, and ultimately decreased quality of life. This pictorial representation, right, centers that person, and the multi-organ or multi-system diseases or disorders that might impact their lives. So this really, resonates with me, this type of thinking. In my world, in neonatology, we are generalists of the newborn period, and our babies, particularly those who were born early, are at risk for all of these multimorbid conditions by the time they're ready for discharge from the neonatal ICU. We know they're associated with adverse childhood outcomes, though they're really not very well characterized, and we'll spend some time talking about that today. We know that multimorbidity diagnosis counts are actually often used in risk prediction models for future developmental impairment. But again, there are some significant conceptual and methodological flaws to those existing risk models. I want to just take one moment to talk about children with special healthcare needs because this is a related, though yet a bit of a different concept as well. One that in the MCH world we certainly think a lot about. This is a service-based definition for individuals who are born less than 25 years of age, or who are less than 25 years of age, who have or are at risk for either chronic physical, developmental, behavioral, emotional conditions, and require more health and related services than other children. So it's having multiple conditions, and those conditions need to have an impact on the amount of services that that child needs. They actually are quite common. Almost 20% of children in the US have special healthcare needs, according to the latest data we have available. So thinking about the world of the preterm infant and my world in neonatology, we certainly know that there's an gestational age dependent risk for mortality based on how early you're born. On the right panel of this slide, you see that there's also a gestational age dependent risk for having morbidities after you leave the neonatal period um, with being, birth at the earliest gestational ages, having the highest risk of multimorbidity. We have seen some improvement over time, and that's what's depicted from in this graph from a really nice recent paper. Though we still, I would say, have a long way to go. Um, Seeing that 30 or 40% of the babies that we care for in the ICU will still have multimorbid conditions by the time they're ready for discharge. We also know that over time, our patients are at risk for chronic health and developmental problems. Problems that I spend a lot of my time thinking about as someone who's focused on the post-discharge life of our patients. And I know I see on the call our wonderful colleagues from developmental and behavioral pediatrics who run our follow-up clinic and spend so much time caring for our patients. We know that there are chronic health problems related to prematurity. You see here on the left panel, and on the right, problems of neurodevelopment in terms of language and motor, cognitive functioning, executive function, and academic achievement. In our world, both in terms of our clinical focus after kids go home from the NICU and the research world in neonatology, often we think about these problems as being very, very separate. And I think that's perhaps for good reason, right? I mean, you need to have some level of expertise and drill down on the pathways, the mechanisms, the outcome, the impacts, right, of these different chronic health problems, understandably. But we tend to think of them as sort of isolated, separate organ system problems. But again, coming back to, being neonatologists, we're generalists of the newborn, and I see myself as a baby's first pediatrician thinking about the whole baby. And can we think about pulling these problems together to, again, use that framework of multimorbidity to put the patient at the center and not the organ system or the disease process? So here are some questions that I've spent some time thinking about over the last several years that I'd like to share with you today. What is the interplay between these multiple morbidities in the preterm infant? What does neonatal multimorbidity tell us about later health outcomes? And are there perhaps parallels between neonatal multimorbidity and that experienced by older adults, particularly on its impact on quality of life, functional outcomes, and this concept of frailty and early mortality? So first, we'll spend a little time thinking about how do we link physical health and development in the preterm infant. And I've spent some time in my earlier work exploring this. I won't go into too much detail because I want to spend more time a little further on. But just to give you some highlights, we know that special healthcare needs are impactful on children who are born early. This is a study I did with my mentor, Marie McCormick in Boston, looking at broad math and broad reading skills, so academic achievement skills, scores in a low birth weight population. And you certainly see that there's an impact of both having special healthcare needs and not on your test scores, both at age 8 and at age 18. We also looked at sort of whether or not full-scale IQ would sort of explain this or modify this relationship, and it actually didn't seem to be, which is something that often people sort of use as an explainer, right? That, oh, children with special healthcare needs, they have lower IQs, and so, or they're more apt to have more difficulty with things like academic achievement and school performance, but that actually is not so borne out that even those with full-scale IQ and special healthcare needs have lower achievement scores. We went on to do an exploration in a cohort of children who were born preterm out of Cleveland. My first mentor, Maureen Hack, had a very robust set of cohorts of low birth weight infants, early gestational age infants with term peers to compare them to. And here we're looking at the effect of being born extremely low birth weight, again on academic achievement scores in adolescence, this time is age 18. And here I'll just give you a high-level overview, thinking about the role of special healthcare needs here as both a modifier and a mediator of poorer academic achievement scores. I show you on the right the calculation or the math-based scores at age 15, and found really interestingly that there's the total effective birth weight, which is about 15 points, um, about a full standard deviation on this particular test, the Woodcock-Johnson test of academic achievement. Um, Half of that was explained by just the direct effect of being born early, and the rest was a combination of mediation and moderation of having special healthcare needs. Again, showing us that if you have chronic problems over time, it's going to have an impact on the effect of your being born early on your achievement or your achievement scores, at least. I then moved on to taking a bit of a deeper dive to two different, very rather highly related chronic health problems in the preterm population. Again, as a little bit of a proof of concept and to try to really get a sense of how do physical health and development sort of play with each other over time. Bronchopulmonary dysplasia, or BPD, is the most common morbidity among preterm infants. It affects lung health, lung respiratory function. Uh, I'm so sorry, our fire alarm is going off. I'll let you know if I need to run away. Um, BPD is associated, the severity is associated with other morbidities in the neonatal period. It's also associated with poor pulmonary function, as I noted, ADHD diagnosis, especially the inattentive type, special ed services, and the symptoms and the impaired pulmonary function that go along with those symptoms persist into adulthood. Interestingly enough, in the term-born population and the rest of the pediatric population, asthma and ADHD are also highly correlated. There has been some work done looking at longitudinal trajectories of those two, and it's really unclear what that relationship really is. Some have found that their severity of symptoms sort of impact each other, that those with more severe asthma have worse ADHD symptoms. Others have shown that not to be true. But I think that there is something quite interesting in looking at this relationship, particularly in this higher risk, sort of this really enriched high risk population of preterm infants. We know here on the left-hand panel, you see that the pulmonary function over time declines for all of us, unfortunately to say, over our lifetimes, but it's the slope of that decline is far steeper for preterm infants. We also know that people with ADHD have different trajectories of their symptoms, and some may have early onset and remission, some may develop at later ages, and there are lots of different types of trajectories. We don't know so much in our patient population in preterm infants really what that relationship is quite like. So we did a study trying to elucidate some of those pathways. This is a study that I did using data from colleagues in the UK from the Epicure cohort of extremely preterm infants and again term-born peers, looking at the impact of pulmonary function at two time points on inattention scores. And I chose to focus on inattention because that's the type of ADHD that our preterm population is far more at risk for than the hyperactive type. I have here am presenting the end result, which is a path analysis of looking at the various relationships between preterm birth or extremely preterm birth, rather, FEV1, which is one of the metrics of pulmonary function at age 11, then at age 19, and its impact on inattention problem scores at age 19. You'll see highlighted in green are the significant associations between these different variables. To me, I mean, it might not be that surprising that the lung function at age 11 and 19 are lower among preterm infants. And so there's a direct line between preterm birth and lung function. But the lung function at age 19 was highly correlated in a negative way to inattention scores. The other very surprising thing from this set of analysis is that FEV1 or lung function at in childhood and adolescence completely explained the impact of extremely preterm birth on inattention, showing and giving evidence for it that chronic health problems, again, are really quite impactful um, on developmental outcomes for our preterm population. A second set of analyses um, was really geared towards looking at trajectories over time, looking at asthma diagnosis, and seeing if there's a differential effect on attention symptom trajectories in high-risk preterm infants compared to term-born peers. For this, I collaborated with a group in the Netherlands who has a very robust and very large birth cohort, 10% of whom are born preterm in Rotterdam. These analyses showed in the top panel on the left, you see inattention scores increase over childhood from age 3 to age 14 years. It's likely not surprising to any of the pediatricians on the call here. On the top right panel, I've looked at the difference in scores over time by asthma diagnosis, and children with asthma diagnoses had higher scores than those without. What was more surprising is in the bottom panels, A and B, we see the difference in between asthma diagnosis impact on those inattention scores between full term and preterm infants. And in the preterm infants, in panel B on the bottom, you see a 5-point difference in this uh, uh, inattention scores, which was quite significant by age 14 years. Again, showing us that this interplay between um, sort of physical chronic health problems and other developmental problems is rather significant for the preterm population and not quite as much for the term population. I will now turn to thinking about multimorbidity and risk prediction. As I noted earlier in the talk, that there are several groups have used this idea of multimorbidity, neonatal multimorbidity, those problems that preterm infants experience by the time they leave the NICU, things like BPD, as I mentioned, necrotizing enterocolitis, intraventricular hemorrhage, all of that alphabet soup of diagnoses that our patients may have. Used counts of those to predict later developmental problems. There was a meta-analysis a few years ago that there were 31 studies with many, many models incorporating morbidities with other factors. Risk for poor outcomes in one, uh, which was defined as death after 36 weeks postnatal age, survival with a major disability or functional limitations, increased with each additional morbidity diagnosis. We see high correlations and high odds of impairment early on in toddlerhood when you add each morbidity to the models. The most famous, I would say, in our world of these models is the one developed by Barbara Schmidt and her colleagues that found 3 morbidities to be most impactful both at 2 years and 5 years of life, and that was BPD, serious brain injury, which is intraventricular hemorrhage, and severe retinopathy of prematurity to be impactful. A few years ago, I led a study, a narrative review of these different morbidity models, and found actually that most of them, first of all, curiously, though there are several of them out there, aren't really used in clinical practice. And it made me wonder why. And it seems like there are some conceptual and some methodologic real limitations to what these morbidity models, how they're put together, how they're conceived, what they're predicting. Um, this led me to think more recently, can we maybe think about how to improve them? Can we tackle some of these limitations? The first way I wanted to approach this was first thinking about, I'm sorry, I'll move back here for a second, um, to think about the limitation, in my view, of just predicting low Bailey scores or low scores on developmental tests, right? What does that really tell us? We know that individual scores at one time point aren't really predictive of future functional outcomes. They don't tell us very much about the added healthcare needs, and it certainly doesn't tell us anything about the impact on the family. The second piece that I was interested in is noted here by these squiggly lines. The prior morbidity-based models really didn't take into account that these morbidities are not independent, they're not isolated, and they actually um, covary with one another, and they weren't really that wasn't addressed methodologically. So our group decided to tackle at least a couple of these uh, limitations to test whether a multimorbidity-based latent class model, and I'll explain what I mean by that in a moment, predict service use and neurodevelopment in early childhood better than using just counts of morbidities alone, like the existing models do. We used data from the Vermont Oxford Network, ELBW follow-up database, 8,000 infants or so who participated in the 24-month follow-up. The outcomes, in addition to using the impairment, which was based on the Bayley scales of infant development, which is a rather standard tool in the area, we also were interested in predicting therapeutic service use after discharge and rehospitalizations. Our predictors were the following set of multimorbidities: BPD, IVH, as I mentioned, PVL, which is a form of brain injury to the white matter, retinopathy, infection, neck, and spontaneous intestinal perforation. Our latent class analysis really aimed to address this issue of the independence or non-independence of these different morbidities. And what it tries to do analytically is to group individuals into classes based on some latent or underlying quality or characteristic based on their profile of morbidities, recognizing that maybe a few of these morbidities may be more likely to co-vary or co-occur in an individual than others. So we constructed three models, one with these latent classes that we developed, then looking at just morbidity count alone, and then using the three morbidity Barber-Schmidt model. And we compared uh, the model calibration and discrimination, sort of how well do they actually perform. Here I show you on the left the rates of each of these morbidities and the likelihood of having a multimorbidity. So 35% of these ELBW infants had two or more of these morbidities at the time of hospital discharge. On the right is our latent class item response probability model that shows four different classes which really fit our data the best. One was fully explained by BPD, and as I said, that's the most common, right? 45% of the kids had it, so that's the most common multimorbidity or morbidity in this group, in this population. And then the others were characterized by different patterns of morbidity diagnoses. I know this is a lot of numbers and a really busy table. The point here is to show that the effect estimates, and here we used adjusted risk ratios, for having any support after discharge, for being rehospitalized after that initial NICU hospitalization, and having any Bayley domain under 70, so two standard deviations. They're all very similar, right? No matter what the model, the latent class, the morbidity count, or the multimorbidity, the three morbidity count Schmidt model, they're all about the same, okay? And so I don't think that we really gained very much here in terms of what the effect estimates were. In terms of the risk model metrics, the fit, the calibration is how you sort of determine the model fit, and R squared was fine. It's an acceptable R squared, which is essentially saying that our model explains 72% of the total variance in the data, which is acceptable in industry standards. Where the models really fell apart was model performance in terms of discrimination. So discrimination is the ability of a risk prediction model to discriminate between two different risk groups. And what we were hoping to do is discriminate between children who were at risk for these outcomes and children who were not at risk for these outcomes. And you can look at this in a number of different ways: sensitivity and specificity, or model, test characteristics that we're used to, positive and negative predictive value, and then the area under the curve. You'll see here that the positive predictive value of all of these models is zero point 0.3, which is pretty low, right? I would say that just is not a helpful test. The negative predictive value, though, it's 0.86 for all of them. And then it tells us that, okay, if you don't have multimorbidity, then your outcomes are probably going to be okay. But if you have them, it doesn't tell us very much of anything. The area under the curve is zero point 0.6 for all of these models, which is also quite low. And I'll just to orient the listeners, an area under the curve of 0.5, 50%, is equivalent to flipping a coin. So in terms of a predictive model, this is not very good. I'll also say we did a sensitivity analysis looking at the role of gestational age alone, and that performed exactly the same. So it tells us, what does it tell us? Multimorbidity can be helpful if it's not there. But if it's there, it isn't helpful for predicting outcomes. And it doesn't really tell us much more than gestational age alone, which is also not all that helpful for discriminating high and low risk infants, which, of course, as a neonatologist and someone who spent many years taking care of kids in a follow-up program, at least for the first 3 years after discharge, I think that's about right. A child could come through the door knowing their gestational age alone really wouldn't tell us all that much about what to expect. So with this, I think perhaps as a long wind up, sort of thinking about multimorbidity um, as a backdrop, I'd like to turn a little bit to thinking about, is there room for improvement or is it time to move on? And this is where I'd really like to get a bit more specific about this concept of vulnerability of preterm infants and perhaps thinking about this new paradigm of premature age or accelerated aging. So again, I come back to this narrative review that we did a few years ago, and uh, to turn to two more limitations of existing risk models based on multimorbidity. One has to do with a lack of biologic specificity and really a lack of attention to all that we've learned about the biology associated with prematurity and um, chronic health problems. And the last one has to do with how do we choose um, outcomes of interest and important to whom, right? And at what time points. So first, let's think a little bit about the biology of aging and why I'm spending some time thinking about this and exploring it. The first point I'd like to raise is this idea of telomere shortening. And dysfunction are related to many age-related diseases in adulthood. And you see here a figure from a nice paper that shows all the different organ systems that have been associated, at least, with telomere shortening. And as a reminder, for those of us who are long outside of any kind of bench research, or exposure. Telomeres are those little bits at the end of our chromosomes, bits of DNA that during the cell cycle replication, they shorten, and that telomere shortening is related to cell senescence and death. Some attention because we learned that from the adult populations in preterm populations, people have been interested. A colleague of mine in Boston showed that telomere length declines between birth and term equivalent age among very preterm infants. In the middle here, you see a paper that shows telomere shortening dramatically between birth and term equivalent age in preterm infants. But then after about a year, that shortening plateaus in comparison with term infants. This is in contrast to on the right here, a really nice paper that showed telomere length is really far shorter among preterm infants or adults at 45 years of age compared to term colleagues or peers. So, it's a little bit mixed, and I think the telomere story that there might be more to tell. It does seem like that's gone out of favor a little bit, though there are people, of course, still studying them in various contexts. But there's this I've noticed a shift, at least in the pediatric world, to thinking about cellular aging and changes in methylation and methylation-based clocks. showing evidence of age acceleration, which in adults, again, we've seen associations with multimorbidity, with frailty, and early mortality. In preterm infants, we've some colleagues of mine in at MCHRI have developed specific epigenetic clocks for preterm infants that predict both postmenstrual and postnatal age better than DNA other methylators, so other estimators, sorry, that have been developed in adult populations. They've also shown that there's actually markers. Epigenetic markers of neonatal multimorbidity associated with aging. And you see here a heat map on the left that shows a number of different problems in the neonatal period and different age clocks, and their neo age clock highly related with accelerated aging associated with particularly BPD, but other chronic health problems. On the right, neonatal multimorbidity is also associated with markers of advanced cellular aging. They developed a multimorbidity score, and you see actually almost stepwise increase in post-menstrual age acceleration. And acceleration is defined by sort of the difference between your chronologic age and your cellular age based on these epigenetic clocks. And they found again that it's associated with a number of these multimorbidities. Other groups have looked at accelerated biological aging in extremely low birth weight infants. This group, I believe, is part of the Elgan Echo consortium and has looked at a group of ELBW infants. Oh, I'm sorry. No, this is out of Ontario. My apologies. But found that epigenetic age, again, sort of looking at this difference between methylation and their predicted age, found not necessarily a direct link between birth weight here, but a birth weight group and sex interaction with low birth weight males showing accelerated age compared to the females and to the term-born men and women. And this group, again, I think this is from the Elkan Echo group, sorry, found cumulative risks in adulthood, I think sort of linked to either chronic health problems or functional outcomes related to age acceleration among ELBW infants with changes in methylation age acceleration again, linked to almost in a stepwise manner to the number of these cumulative risks in adulthood. So, I'm sort of taking a perhaps a high level and fast overview to some of the information around aging and prematurity. And I'd be happy to talk more in depth with anybody who's interested at later times. But I wanted to give that as some introduction to some work we've done thinking about multimorbidity and epigenetic age acceleration. Um, to really sort of, again, to think about proof of concept and putting together some conceptual models of how we can think about prematurity and multimorbidity and later outcomes. So the rationale for this particular study is that epigenetic age acceleration is the extent to which epigenetic age outpaces chronologic age, and it's associated with individual pediatric diagnoses like attention and attention deficit disorder, so ADHD, in term populations. But its utility as a biomarker for multimorbidity in children, it really hasn't been established. And so we were able to leverage data that's available from the Future Families and Child Well-Being study out of Princeton and Columbia to test two hypotheses. One, that pediatric multimorbidity is associated with accelerated epigenetic age acceleration in adolescence. And the second is that the effect of multimorbidity on epigenetic age is greater than for atopy and ADHD alone. The results were quite interesting to us. So the table on the left shows the results of three different regression models. The first using atopy, the second ADHD, and the third multimorbidity to predict epigenetic age acceleration using the Horvath pan tissue estimator, which is one of the epigenetic clocks that's out there. I think it was the first, if not the first, one of the first to be developed, and it has used both pediatric and adult um, uh, tissues for benchmarking. What we found, at least in this cohort, is that atopy and ADHD really didn't predict age acceleration as it had in some prior studies from other groups. We did find that multimorbidity was associated with almost a year and a half acceleration of epigenetic age past that of chronologic age, and that's just depicted in the figure on the right-hand side as well. So those differences between having multimorbidity and not was associated with faster cellular age. Um, I think that's all well and good, very interesting. As a neonatologist, again, I'm really interested in thinking about, well, what about for my patients, the patient I take care of, particularly the low birth weight or preterm population, who I spend so much time thinking about? Are these patterns the same? Is there a differential effect of multimorbidity like we saw sort of on the impact way before, the differential impact on attention scores, on academic achievement? Is there something different happening at the cellular level as well? And so this data set also has information on birth weight. And we looked at the effect, again, looking at here multimorbidity and low birth weight, and then the interaction between the two on age acceleration. Here again, we found about a year and a half difference in uh, cellular age, sort of advanced cellular age compared to chronologic age. But interestingly, there's really no effect of birth weight or on the interaction between multimorbidity and low birth weight on um, uh, age acceleration, at least at age 15. So right now that tells us, well, maybe our hypothesis is incorrect. Maybe there really isn't a story here of birth weight or prematurity, though of course we haven't measured prematurity in this data set. Um, the second piece, so this is taking care of sort of thinking about one set of questions, bringing in the biology. I will transition a bit, and I want to say, yeah, just to show thinking about alternative outcomes, right? So as I had said before, one of the other limitations of existing risk models was that we were thinking, or others have really been focused on test scores, and not so much on what the impact of those developmental test scores are on the child or on the family. In this particular cohort, they measured adolescent well-being among the participants. This is at age 15. And this is a standardized measure of engagement, perseverance, optimism, connectedness, and happiness. Perhaps not surprisingly, that having multimorbid conditions was associated with lower odds of having sort of top box or sort of the highest scores on three of these subdomains: perseverance, optimism, and happiness. Um, but again, having low birth weight was not associated with any of these. And this actually is consistent with existing literature from several pioneers in the field who have actually followed preterm cohorts through adulthood, and they have actually reported actually quite good quality of life. So perhaps this isn't surprising, but the impact of multimorbidity in childhood seems quite impactful. Other groups have looked at this idea of age acceleration. Stephen Miller's group from Vancouver has found an association between pediatric buccal swab epigenetic age acceleration with slower brain growth and developmental outcomes at 18 months. There are several groups actually who are looking at phenotypes of premature cardiovascular aging among the preterm population. Then those are really sort of physiologic and some sort of echocardiographic outcomes that they've looked at. And then there's a really nice recent paper in the last 2 years from a group thinking about premature birth and preterm premature kidney disease and risk of actually chronic kidney disease in adolescence and adulthood related to prematurity, and sort of thinking about what are the impacts of these markers of cellular aging, thinking about not just the methylation that and telomeres that I've talked a little bit about, but things about things related to chronic stress response and inflammation as well. Um, Rebecca Fry's group has put together a very nice review paper in Children a couple of years ago now, um, really pulling some of these concepts together, thinking about preterm birth causing accelerated aging phenotypes in following in these organ systems. And really thinking again about these different types of biomarkers, cortisol, right, epigenetic profiles that you can measure and track over time. Yet we haven't really seen that. These are I think concepts that are born from first principles and some of the data that we've collected and others have as well, but we haven't really tested it. So my group put together a conceptual framework last year, um, thinking about the effect of preterm birth over the life course, and really thinking about this concept of maturational vulnerability. That prematurity itself, gestational age itself, is not predictive and it's not destiny. As I've said, you can have a child born at a given gestational age, and it doesn't tell you all that much about their future health and development over time. But there is a vulnerability there. And might neonatal multimorbidity be either a reflection of that vulnerability that we haven't been able to measure, or is it contributing, right? Um, Along the causal pathway to other complexity, developmental delays, impairments, and then in later adulthood, chronic disease and maybe frailty phenotypes at earlier ages than their term-born peers. Of course, having to recognize the context in which the baby is living, right? In the family and social context, all play a role. These things haven't really been measured. Certainly, some pieces have, and there, as I said, there's some evidence to help support some of these theorized relationships, but we haven't really pulled together this type of conceptualization yet. So to bring us back to this idea of pulling all the pieces together, right? All of these different organ systems and all of these different um, problems, chronic health problems that children may have, and really trying to think about what are the outcomes that are most important. And I love this conceptualization from the Canadians have reimagined the International Classification of Disability for children and youth to really reflect the things that are important to children and their families. And they've dubbed them the F words in a provocative way, I suppose. But thinking about function, about friends, about fitness, family, and fun. And the sixth one they added sort of after the initial publication was future, right? Really thinking about longitudinal trajectories and the life course health development of children. This is reflected in what families tell us they're really interested in. They're interested after going home in development, first and foremost, their respiratory health and concern about infection and its impact on their respiratory fragility, nutrition, feeding, and growth. My colleague and good friend Paige Church in Boston has sort of conceptualized this cauldron of the NICU as being, sort of this soup that families are sort of swimming in, positive, negative, good, bad, and otherwise of things that are impacting them and their children, but thinking that that they bring with them their own beliefs, values, and biases, as do we as providers, and really needing to sort of sort through that to really ask the questions, what do they find important and valuable so that we can actually help bring evidence to bear to help them understand what their child's future may or may look like, and to be able to build systems around them to help support the optimal development. So, thinking about measuring what counts, right? We've used diagnoses, symptoms, and test scores. Sure, they can help us, and certainly, in terms of our own academic work, as scientists and clinicians, it's important. But families have told us things like activities of daily living, independence, participation, stamina, are things that they spend a lot of time thinking about and ask us about. Um, I like this definition of child health, sort of as the extent to which individual children or groups of children are able or enabled to develop and realize their potential, satisfy their needs, develop the capacities that allow them to intersect successfully with their biological, physical, and social environments. Um, there are several groups that have thought about this for years and quite frankly decades. This concept of positive health, health-related quality of life. Of course, there's a functional status and disability. This a PD measure tool of functional disability in children, and then of course the impact on the family is really important as well, and one that I think we often clinically don't really think that much about. Um, a scoping review from a few years ago really tried to think about how do we measure child and youth thriving, and found that there were a number of different frameworks and measures that are out there in the literature that are really trying to assess things like the strength of minds and bodies and self-identity and worth, caregiving relationships, safety, health environments, and even things like racial justice, equity, inclusion, right? That are all sort of part of this concept of thriving. Um, I have the privilege of being a part of the Life Course Translational Research Network that's based down at UCLA, that is really trying to help think through how to operationalize some of these concepts. And they are at work with something called the Thrive Center at Georgetown to really bring together how do we not only define thriving in childhood, but then how do we measure it, right? Because it's so can be so subjective, right? It can be so individualized, so it can be really difficult to come up with a systematic way and a validated and reliable way of measuring it. And of course, as scientists, really important thing to think about. But I like thinking about outcomes in this rather positive sort of strength and asset-based way, rather than the adult population, right? The literature around multimorbidity and aging really has to do with frailty and premature death. And it may be just that it's reflecting different parts, right? It's different ends of the life course, and I can understand that. But I certainly wouldn't want to leave you here today or anyone who's sort of engaging with the work that my group is doing to think that we want to be predicting things like premature death or frailty or not thriving, right? I think the whole idea is to think about how can we actually optimize outcomes for our patients. And to do that, we need to know what are the inputs and what are the outcomes. And so I really like this idea of thriving and defining it and measuring it well. So with that, I will wrap up. I think we have a few minutes, but I'll just say that let's see, I have some work underway to sort of think about risk prediction and how we can maybe use better definitions of multimorbidity, and I didn't really get into that during this talk, but the diagnosis is binary, and maybe that's not enough information to be able to help predict outcomes. Can we think about health-related quality of life, functional disability status? For our babies, particularly in infancy, we don't ask them to do very much, but feeding skills is one of the major activities of daily living, and it can be quite dysregulated in our patients. So perhaps we should be trying to predict that. And then bringing in the biology, right? Thinking about epigenetic age acceleration as one marker of aging. And might that be helpful to us in prediction? Some other questions that really haven't been answered that I'd love to think about. I'm engaged with, and hopefully, if there's anyone out there who's interested, I would love to talk more and collaborate. But thinking about, does neonatal multimorbidity predict multimorbidity in later life? We actually don't have very good evidence of that. How does neonatal multimorbidity impact functional ability and quality of life? As I mentioned, what is the impact of the NICU environment on markers of cellular aging. This is an area that I think is really underexplored, thinking about both sort of the noxious stimuli, pain and stress, of course, but then the nurturing, the buffering impact of things like skin-to-skin care and developmental care and reading and singing to your baby and all the things that we know are really important. We don't know the impacts. Do markers of cellular aging enhance the risk models, as I mentioned? And does accelerated aging explain the variable outcomes, or at least in part, help us understand the variable outcomes of our patients after they go home? So with that, I will say thank you to you all for being here, to my group, my co investigators, my funding for my K-23 and the MCHRI Faculty Scholars Endowment. And I would love to have some time for questions and discussion.
Thanks so much, Jonathan. That was really wonderful. Love to have folks come
Welcome.
off mute or feel free to use the chat if they have any questions.
So that was truly fascinating,
Thank you.
especially the thing about telomere reduction.
Yeah.
But I would say that prematurity is a big cause to have shortening of telomeres, and it's just hard to tease out what's shortening it. I wanted to ask you, because you're aware of all of these different things that kind of affect later life in these patients, the discrepancies in pulmonary function
Mm.
that you describe are very well known in the pulmonary community. I did a session on transitions in pulmonary care at this year's CHEST meeting, and one of the discussions was transition of BPD patients
Ah, yes.
because adult pulmonologists are not prepared for them.
No.
Since much of adult pulmonary care is centered around children not surviving, but now they do.
Yeah.
And so they're not actually ready for it. And it's a big talking point within the pulmonary community. What I specifically wanted to ask you is I know that there were many factors that were considered as contributing to morbidity, and you had one of these, I think, meta analysis studies that was talking about sleep apnea.
Yeah.
There was nothing that was specifically talking about hypoxemia. Are
Mm-mm.
you aware of any study that has specifically looked on the duration of hypoxemia exposure based upon birth weight and then these kind of multimorbidity consequences?
No, I'm not, but I would say stay tuned. There, the most of the literature that I'm aware of that looks at hypoxemia is looking at very short-term outcomes and not longer-term outcomes. And I think I think you're right to ask that question, and that's certainly one of the hypotheses that we all have is that okay, are these long-term problems related to exactly that, right? That you're either hypoxic or you're hypopnic, or like there's some interplay there. Um, we just don't know, and I think, excuse me, part of the major problem is that our data sources aren't aren't very robust here, at least in the US, right? That it's hard to find data that links at least clinical data, the NICU experience to later adult outcomes.
Mm.
Um, so I'm not sure. I don't think there is any.
And then is there any partition of sleep apnea into obstructive versus central?
Mm. So I think it's obstructive as far as I know and not central.
I see. Okay.
Yeah.
Thank you so
So
much.
the central part should be resolved by the time yeah,
The
later
the
on.
central part is actually not resolved, but
No?
leads to great anxiety within the ENT community. And so we address that by doing these bedside polysomnogram studies. But for decades,
Right.
people haven't actually figured out
Yeah.
whether central apnea is good, bad, or just something that happens in humans. So that was my interest in trying to see
Yeah.
if people had actually partitioned it or if there were databases that actually partition it so that we could kind of tease these things out because we have been working on data from the SID studies that were
Yeah.
done in the 1980s.
Right. 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 Yeah. I understand, but I don't think there's, from my understanding, that there isn't a different contribution of central apnea in this patient population as children age, I guess is my point. Yeah.
Okay, great.
Thank
Thank you
you.
so
Yeah.
much.
Yeah.
Thank you so much. We just got a question in the chat from Mahali. I'm curious to know if maternal metabolic stress affects the developing embryo,
Yes.
which leads to multimorbidity in infants leading to prematurity.
Yeah, really important question. I don't think we know the links to multimorbidity in the preterm population. But we certainly know that the in utero environment is also really impactful. And I left out a whole part of the literature here around the epigenetics of the placenta itself. And there's actually been quite a lot of work on sort of the accelerated aging in the placenta based on maternal stress and other impacts. And then future outcomes of babies, and particularly um, prematurity and growth restriction, in utero growth restriction. But the particular then looking at later outcomes of those babies, I'm not at least aware of. Um,
Thank you so much. It looks like we are at time. We are so thankful for your time today, Jonathan.
Sure thing.
Thank you for the presentation. It was riveting. This will be recorded, as mentioned, and we will post it on our website. So please join us December 8th for our next seminar and hope everybody has a great Thanksgiving. Thank you.
Thanks so much, Grant. Thank you. Bye bye.